And so we attempted for 20 or even 30 minutes to get a wire in the bile duct, but we were not successful. So in the same session, we then moved to choledochoduodenostomy. So here you see the scope is in the duodenum, and we measure, it was 13 millimeters. And then we use Doppler to see that there are no blood vessels. And of course, 13 millimeters is not a lot. So in these cases, when we have less than 15 millimeters, we introduce a safety wire right after our catheter has entered the bile ducts. And then we deploy the stent. So the question then raised, of course, did we not expose this patient to a risk of post-ERCP pancreatitis that maybe was not necessary? So he had an elevation of his pancreatic enzymes the day after, but fortunately no abdominal pain, so no post-ERCP pancreatitis. So yeah, is EUS-guided biliary drainage to be preferred over PTC or even ERCP in neoadjuvant setting? I think we discussed it. I think we have some meta-analysis showing that EUS-guided biliary drainage should be preferred over PTC, not in terms of success, clinical success or technical success, but in terms of complications. In our center, we have vast experience in PTC. We have an excellent interventional radiology group. But we also do interventional EUS. So it depends a little bit. I mean, maybe I can ask Elisabeth, what do you feel is the indication still for PTC in this kind of patient, in neoadjuvant setting? Do you feel that there is still a role? And
I think it really depends from center to center. If there's a vast experience with EUS-guided procedures, then I think this might be more indicated in this situation than PTC.
So it's a quick procedure, but in experienced hands. It has a very high success rate. It allows all conventional ERCP and EUS techniques through the LAMS. However, it's challenging. It requires a combination of EUS and ERCP with transmural LAMS placement. And as already mentioned, in experienced hands, it looks like a little boy's game, but you have to be experienced. It is usually a multiple step procedure because you create a fistula between two lumens and you cannot just put in the stent, dilate it, do the ERCP, pull everything out and pull out the stent again, because that will leave you with a hole, even if you try to close the holes. So usually it's done in a multiple step. It becomes more costly also, and it has higher complication rates. And usually these are serious complication rates because we're talking about perforations. LAMS can migrate during the procedure. There is a discussion about fistula closure, although I don't think that is a major problem. And the technique of EUS-guided drainage is not suitable for all surgically altered anatomies because you don't always have the access of an excluded stomach, or the hepaticogastrostomy is not always feasible, like, for example, in the total Roux-en-Y gastrectomy.
That's what we are, or hatchet.
Any further questions, comments, remarks, additions?
It's very, very interesting overview of, with all the variables, the challenges, and as Mariana said, no one size fit all patients that you have.
No.
So we can be agreed.
And despite all the publications coming out, I think the main reason for one center taking that technique over another center is common local availability and expertise.
Locally, yeah.
So I think it is best to rely on your own expertise, whatever the technique is, as long as the clinical and technical outcome is good, then there is, I think, no technique better than the other. The only good technique is the one that you have a lot of experience in with good results. Yep. And that's why I showed you our treatment algorithm, which is not the treatment algorithm.
Okay.
Thank you very much, Tom, and
okay.
Thank you.
So that brings me to my last slide and the conclusions. Surgically altered anatomy predisposes to biliary stones and obstruction. there are different therapeutic approaches available, and they are mainly used because of local availability and expertise, which is very understandable. Also, depending on the surgical reconstruction, because not all techniques can be used in all surgical reconstructions, and also because of the biliopancreatic indication itself. As already mentioned, for gastric bypass, for example, simple bile duct stones, we always go with the enteroscope, and all other indications we go with edge. However, these remain challenging procedures, and I think you always have to have a first and a second line approach available. So it's better not to put all your money on one single procedure, because even your one single procedure, if you have a lot of expertise, can fail, and it's better to have one or even two second or third line approaches available. And with these approach, you can, even in these difficult patients, acquire high technical and safe success rates. Thank you very much.
Thank you. Any comments from the co-moderators? Yeah.
As a surgeon, I miss one type of solving the biliary stone problems. That's it. So we changed a little bit the order in the way that in patients, and I don't know how many patients in your nice series of 102 patients that needed a cholecystectomy. We have the technique of the laparoscopic common bile duct exploration. And I think considering the one-stage procedure, that if they need a cholecystectomy anyway, we start with that, do a cholangiography, prove that there are stones. If there are, we do the common bile duct exploration. If we do not succeed, which might happen, of course, once in a while, then we send them for further endoscopic treatment. So I think in centers, and I think all the centers here are experienced HPB centers, that is an option that should also be evaluated, just to add to your nice overview.
No, I fully agree. Although, let's say in our center, the surgeons, they also do the biliary, the bile duct exploration and the peroperative cholangiogram, but they are usually not very happy when there is still a stone inside, and they prefer to have the stones cleared from the bile duct before starting the operation.
To make life easy, and yeah, that's true. Yeah. Of course, for the patient, it's a double procedure.
Yes. Yeah.
But then that patient, after the laparoscopic common bile duct exploration, when he gets a leak, you get to do the ERCP and sphincterotomy.
Yeah.
You should do nice surgery, of course.
Yes, but there are no surgeons without any complications.
No, but also no endoscopists without complications.
That's true. That's true.